All right, you guys. Thank you to everyone in the room and that have joined us online. This is, ooh. Okay. I just wanted to say 2 thank yous before we get started with our speaker and our intro. That I'd like to thank the American Society of Microbiology for hosting us. We were so grateful for them to provide this space for us and allow us to give you and share this information along with the speaker. So thank you to them. And also we have in the room tonight, as you have heard in the room and now you will online, Dr. Cheryl Stroud with the One Health Commission. So we wanted to say thank you everyone online who's partaking tonight. That is made possible by the One Health Commission. So please consider supporting them in the future. We wouldn't be able to do the webinar without them and their support. So thank you to both ASM and the One Health Commission. And I will start off tonight by presenting the presenter to the presenter and Dr. Cheryl Stroud, who will read our bio for this evening. Thank you, Dr. Cheryl.
Okay, hi everybody. Thank you so much for the opportunity to introduce one of my favorite people who I am fortunate to work with as a board member for the One Health Commission. Dr. Lee Willingham actually started his veterinary career at University of Georgia, finishing in the class of '86. We have you? Okay, sorry, University of Georgia in '86, and did 4 years of veterinary practice and then went to the Peace Corps. And that's where I think he got bitten by the parasitology and public health bug, which many of us can relate to being bitten by this public health bug. So then he did a PhD actually at the University of Denmark, and then ended up working in Africa a lot with parasitic disease and livestock, and with ILRI, the International Livestock Research Institute, fabulous organization, and has also worked quite a bit with WHO, most recently initiating the new research program on environmental and climate change impacts on vector-borne diseases, so parasites and all stripes. Thank you very much, Dr. Willingham. We're looking forward to hearing maybe some about schistosomiasis and a little bit about cysticercosis. No? so thank you. Please help me welcome Dr. Willingham.
Thank you very much, Cheryl, for that introduction, and I appreciate the One Health Academy inviting me this evening to give the presentation, and of course thanks to the One Health Commission for carrying this out to those who couldn't be here this evening in person. So I'd like to talk about parasites, yes, parasitic zoonoses, and as Cheryl mentioned, I started my career from a Peace Corps experience, and I'm just coming from having met the director of the Peace Corps just a couple of hours ago, and I'm still floating. Since the past 5 years, I've been the Associate Dean for Research and Postgraduate Studies and Professor of One Health at Ross University School of Veterinary Medicine on the island of St. Kitts. And I'm sure some of you may be sitting there thinking, where is St. Kitts? Where in the world is St. Kitts? So it's in the Eastern Caribbean, not too far from Puerto Rico. Can you see the little yellow circle there now on the map? So it's actually a federation of 2 islands, St. Kitts and Nevis. And this was formerly a British colony, but it's been independent since 1983, and it is the smallest independent country in the whole hemisphere. Together, it's about 55,000 people. St. Kitts is 68 square miles, and Nevis is about 36 square miles, I believe. It's a member of the Organization of Eastern Caribbean States, but they still recognize Queen Elizabeth II as the head of state. We have a prime minister. Up until about 2005, over the past nearly 4 centuries, the main role on the island was growing sugarcane. It was all devoted to sugarcane production. And in the mid-2000s, suddenly everything was changed and oriented towards tourism. It is ranked by the World Bank as a high-income country. And our university, Ross School of Veterinary Medicine, was initially founded in 1982 on the island of Dominica. And in 1983, it was moved up to St. Kitts at about the time the island got its independence and has been there ever since. So we just celebrated our 35 years on the island. We've now graduated over 5,000 veterinarians, most of whom come from North America, especially from the US. And although we've been around for 35 years, or 36 years, we only got accreditation from the American Veterinary Medical Association in 2011, 2012. And that instigated establishment of a postgraduate research program and a formal research program being established at the university. And so our research program has been based around a One Health transdisciplinary approach. And we've established 4 thematic research centers. As you can see here on zoonoses and tropical veterinary medicine, integrative mammalian research, conservation medicine and ecosystem health, and innovation and research in veterinary and medical education. So I was the inaugural director of the Center for Zoonoses and Tropical Veterinary Medicine and was actually recruited to help with establishing the formal research program. And that's because, as we discussed, or as Cheryl mentioned, of my background working with parasitic zoonoses, having served in the Peace Corps, conducting leading research in Africa, also in Asia, and then more recently working at the World Health Organization in Geneva with a special program for tropical diseases research and training. So these are I would say are the most important parasitic zoonoses of public health and agricultural importance, not in any specific order, but I think you may know most of these. But we find that these are very neglected diseases, and it's often because of a lack of awareness of their presence and impacts. Are they there? If they're there, what is their impact? And so that leads to a perception that their burden of disease is very low. Where we do know information on the burden of disease, it may just be on the health side, or it may be on the agriculture side, and nobody really looks at the total societal cost of these diseases. There's also an indecision as to which sector should take responsibility for their investigation and control. Is it health or is it agriculture? Nobody seems to be able to say, well, actually it's both and probably others as well. And so we have to come together for that One Health approach to addressing these. And in many of the developing countries where these diseases are present and causing problems, there's a general lack of veterinary public health infrastructure, which compounds the situation. So these were the zoonotic parasites, but tonight I'm just going to focus on the top 3. These are the ones that I've been engaged with over the past nearly 30 years. Echinococcus granulosis, or hydatid disease, Schistosoma japonicum, or zoonotic schistosomiasis, and then Teniasolium, the pork tapeworm that causes teniasis neurocysticercosis. So yes, I was in the Peace Corps after 4 years of veterinary practice. I joined the US Peace Corps. There was a special veterinary program started back in about 1989, and I was in the second group of a small number of veterinarians that went to Morocco for this special veterinary Peace Corps program. And so the other veterinarians and myself, when we got to Morocco, many of us observed that in the livestock, especially the sheep and cattle, many of them were infected with Echinococcus granulosis. And knowing the life cycle, we expected that a lot of people were at risk of exposure to this zoonotic parasite. And so it became an issue of importance for us. So the first group of veterinarians who were there, I think there were about 5, left, and then 3 veterinarians and myself came in. I think one of the original ones stayed on for an extra year. But then, as you know, in 1990, Iraq invaded Kuwait. And in January 91, we were evacuated for 6 months. We didn't know if we'd be able to go back. And during that time, I went to Denmark to visit colleagues and stayed there for several weeks. And then eventually went back to Morocco. And I was the only veterinarian in the group that actually returned. And so I went back and worked there for almost another year and a half. And so Echinococcus granulosus became a very interesting thing for me, an issue of concern. If you know about the parasite, it's basically transmitted between dogs, which serve as the definitive host. They harbor the adult worm in their small intestine. The eggs pass out with the dog waste. They defecate on the pastures. Then the livestock come and when they're grazing, they ingest the eggs where the dog waste has contaminated the environment, and they develop the larval stage of the parasite. So here you can see, this is a very tiny tapeworm. It's about 6 millimeters in length, less than 1/4 of an inch, and you can see it compared to a paperclip, just to impress on you how tiny this is. And so these dogs, they can harbor thousands of these parasites. You can see here an everted section of small intestine from a dog, just showing you it's completely covered with these Echinococcus granulosus worms. Their eggs are about 25 to 40 micrometers. They look like any other Taenia tapeworm egg, so it's difficult to make a diagnosis of at the specific level when seeing these eggs. You just know that it's actually coming from a Taenia tapeworm. So what happens is those sheep, when they're grazing, they ingest the eggs. The eggs hatch in the small intestine. The oncosphere or embryo emerges and then enters the intestinal wall and into the sheep's body. And then it goes to usually the liver or the lungs and encysts there, and then develops into what we call a hydatid cyst. And I don't have a pointer, but you can see here the liver and lungs. You can see those cysts, and they will be filled with fluid and they will expand. And through a process of asexual reproduction from one egg, you can get thousands of these protoscolices, as you can see here. And these are immature tapeworms. So when a dog ingests that cyst, it's not just one parasite it's going to be infected with. It's going to be infected perhaps with thousands of these protoscolices that will turn into immature tapeworms. So you can see that cyst, there's endogenous budding where these protoscolices are being made. It's a very clever thing for the parasite to ensure that they continue on. So a problem arises if humans ingest these eggs. Say they are in direct contact with the dog, the eggs may be in the coat of the dog, they pick it up that way, or the dog feces may be contaminating food or water in the community, and they ingest the eggs from that contaminated food or water. And then people can also develop these larval cysts in their livers and in their lungs, and it's quite problematic for them. And in those communities where a lot of, in rural communities, especially in North Africa where I was based, the farmers, sheep farmers, are keeping dogs to help them herd their sheep. And then they develop a close relationship with those dogs. Of course, it's an Islamic area. Dogs are considered dirty, but the sheep farmers, they're very dependent on these dogs, so they have a closer relationship with them. And so that puts them at great risk of infection because they may be obtaining the eggs from their dogs when they're interacting with them. But as I said, people can develop these hydatid cysts, and in people, oftentimes these cysts can grow to be the size of a baby's head. And you can see here an example of someone with hydatidosis. I think this is in the Turkana area of North Kenya, which is served by AMREF, and they actually have a program where they go out and do surgeries on these people with hydatid disease. In Turkana, they have a very close relationship with their livestock and dogs. They actually, with their children, when the children defecate, they don't have diapers, so they just call in the dog to clean up their child. So they have a very close relationship with their dogs, and that puts them at great risk of infection. So it's a very serious problem. It may not kill you, but certainly if you can imagine having these cysts in your abdomen or in your lungs, it certainly would incapacitate you. So I learned a lot from that experience. And so some of the outcomes of my Peace Corps service were that I was able to inform the U.S. ambassador at that time about this problem. And it just so happened that the U.S. State Department had this Middle East Regional Cooperation Program on parasitic diseases, and they had not yet included some of the North African countries. And they came knocking on Morocco's door and asked the ambassador if Morocco would like to participate, and if so, what diseases would they like included in this program. And so he said yes, and echinococosis, because I'd done a great job in telling him about this problem. So echinococosis was eventually included in the State Department's Middle East Regional Cooperation Program. Unfortunately, not echinococosis in Morocco because of some complications, but the disease was included in the Merck program. Also, I found out about a program in China that was supported through the Thrasher Foundation, which is a Mormon-based foundation, I think, based in Utah. And they had supported a program in China where they had funded studies and programs there looking at the burden, surveillance, and control of echinococosis in China. So I wrote to them and I said, would you consider doing the same thing in Morocco and in North Africa? And the initial message was no, but a few months after I left, they came back and said, we've changed our mind. So I wasn't actually involved in all of the surveys and surveillance and collecting all that information, but I take credit for having instigated it. So this led to a several years program in Morocco and North Africa. And so they ended up with a compendium that was actually published with all of this data about not only human infection, but also the livestock infection. And then that eventually led to community-based ultrasound surveys. So they take out these portable ultrasound units and actually scan people's livers. And we're picking up a lot of infections that way. And then those people could be treated or had surgery, depending on their particular situation. And I also learned a lot about, not only about myself, but about how to approach these kinds of issues. And I put this quote here. I was in the slaughterhouse and noticing that when they were seeing these sheep carcasses with these cysts, they would just cut them out and throw them out the door to the dogs that were outside waiting to have something to eat, because they were ignorant of what this was and how it was transmitted. So one day I said, you cannot do that. You can't do that. You're causing this problem in the community. People are exposed to this. And they turned to me and said, well, don't tell us it's a problem if you don't have a solution. So we came up with some ideas on how they could actually dispose of this viscera that was contaminated or condemned, so that the dogs wouldn't have access to it. But I learned a lesson from that. Also, certainly the need for a multisectoral transdisciplinary One Health approach, working eventually in Rabat, the capital, with both the Ministries of Health and Agriculture, and serving as kind of a conduit between the two, because they weren't talking to each other there at that time very well. So certainly recognize that importance. And then also the need for integration between the research activities as well as the surveillance and control activities. You know, what were the needs for surveillance and control, and could research, you know, help with those needs? And this is the endemicity map of Echinococcus granulosus today. This is from WHO in 2011, just showing you how this disease is distributed throughout the world. Now, the dark red areas are the areas of highest endemicity. So you can see around the Mediterranean, the Middle East, Northwest China, Nepal, Central Asia, and then the southern cone of Latin America also. So then when we were evacuated because of the Gulf War, and I mentioned I went to Denmark, I met with the head of parasitology at the veterinary school there, told him of my interest in working with parasitic zoonoses, and he said, well, we're planning a big project on that. Why don't you see if there's some way you can come here? So I applied for a Fulbright fellowship. So when I finished my Peace Corps service, I went on to Denmark to do a one-year research study on the zoonotic schistosome, Schistosoma japonicum. They had the parasite in the lab there, and so I did experimental studies in Danish pigs at the Royal Veterinary and Agricultural University for a year. And in the meantime, the research group there got a large-scale grant, $8 million from the Danish government to do research on certain pig parasites, and this was one of them. So they said, would you like to stay and do a PhD? This is how much we will pay you, and you'll have to do some coursework, but we'll send you wherever in the world you need to go to do that coursework. And I said, let me think about that for 2 seconds. And so I took them up on the offer, and so I stayed another 3 years to do the PhD. And so I did these experimental studies in Denmark, population biology studies, looking at, the number of parasites that the pigs were exposed to, how many parasites actually established, how many eggs did they produce, how many eggs actually were excreted from that animal, and how many eggs ended up in the liver. I'll show you in a moment the life cycle, and you can see why. But so that was very exciting, and one of the most exciting things was we infected some pregnant sows, female pigs, and their piglets were infected. So that was quite exciting, and there's actually a nice paper in the American Society of Trout Med and Hygiene Journal of whatever it is, I can't remember the official title, but there's a nice short paper in there about congenital infection with Schistosoma japonicum. So through this process, I also had exposure to scientists working with this parasite in China and the Philippines. That's where Schistosoma japonicum occurs. You can see here the map where the red areas are, and also a small focus in Indonesia. So this is just a little bit about Schistosoma japonicum. You probably have heard about schistosomiasis in Africa, maybe in Brazil. And in those instances, it's a snail-human cycle. But with Asian schistosomiasis, Schistosoma japonicum, over 30 species can be infected with Schistosoma japonicum. So this makes it much more complicated because of these reservoir hosts involved in the life cycle. So you can see here some of the main culprits are water buffalo or carabao if you're from Philippines, dogs, and rodents. So some of the outcomes of that research and engagement with the Asian scientists and control authorities was we actually established a regional network for Asian schistosomiasis, or RNAS at that time. And here, the lesson I learned from Morocco was a way to bring the scientists or researchers together with the control authorities and those involved in implementing surveillance and control activities. And also, we included not only Schistosoma japonicum, but eventually we included another Asian schistosome, which occurs in Cambodia and Laos, Schistosoma makongi. Initially, the network just involved Chinese and Filipino scientists and control authorities, but as we went forward, we added in Cambodia and Laos and Indonesia. And then in 2005, the network decided they needed to add other zoonotic helminth infections in the region. And so that was done. So we just changed, we didn't want to change the acronym, so we decided it would be plus other zoonotic helminthiases. And so we changed the name of the network to RNAS Plus. RNAS Plus is still going strong. They just had their 20th meeting last year. And they should be having another one this year in Vietnam, and I hope to go. We initially got a lot of support for this network from WHO and TDR, but as time has gone by, the groups have had to become more reliant on support from their own countries. And so these are the initial regional research priorities for the network. And so for the first few years of the network, everything was devoted to these three issues: the diagnostic test improvement, standardization of ultrasound for monitoring these infections in people, and then also a better understanding of the role of animal reservoir host with regard to transmission of these Asian schistosomes. Another outcome was a basis for applying to NIH's Ecology and Evolution of Infectious Diseases program, and we managed to get support for a 5-year project on schistosomiasis transmission and ecology in the Philippines, what we affectionately referred to as STEP, the STEP project. And the rationale for that STEP project was that 20 years had been devoted to a control program for schistosomiasis in the Philippines. It had all been directed at the human population involving mass chemotherapy, but also snail control as well. They got the prevalence decreased from a national figure of 17.3% down to about 5.2%, but they couldn't get any lower. And so it was determined that the most likely reason for that is because of the presence of these reservoir animal hosts. The funding for this program, a lot of it came from the World Bank, and so in the end, they were not able to eliminate the disease, and in fact, after these activities stopped, the prevalence increased dramatically again. So we wanted to have this STEP project as a way to look at the role of these different potential animal reservoirs, what role they were having in transmission to each other and to the human population. And we also looked at the linkage with food security, where in the Philippines at that time about 20% of the population were undernourished. And so some of the basis for our application was that infections with diseases such as Schistosomiasis japonica would affect the health and productivity of the farmers and their families, and as well as their livestock. And most of these were small subsistence farmers. They're producing their own food and for their household consumption. So if they're incapacitated, not able to be very productive, then that certainly helped lead to a state of food insecurity. So this is what we proposed in our to NIH, and we got the funding. So that went on for 5 years, led by the Research Institute of Tropical Medicine in the Philippines and Brown University here in the US. So then I'm going to turn to cysticercosis, where we had a long-term project funded by Denmark in Africa, Eastern and Southern Africa. I was coordinating these Danish-funded projects in that region, where we were supporting master's and PhD students at the veterinary faculties as a way of strengthening capacity for research. And so these students were doing studies on parasitic infections or helminth infections of livestock belonging to small-scale farmers out in the rural areas of these countries, which included Kenya, Tanzania, Zambia, and Zimbabwe. And later we added Mozambique, and we did some activities in Uganda as well. That went on for up until about 2007, and then we had a follow-up project just focused on Tanzania and Mozambique, solely looking at cysticercosis, because in that earlier period, it emerged that cysticercosis was widespread in the region, infecting the pig population, which was actually growing quite dramatically during that time. And now we're also looking at this situation of Taenia solium in the Caribbean and in Central America. So a bit about Taenia solium. Since pigs are involved in the life cycle, you're going to find the endemic areas where pigs are being raised and where pork is being consumed. And certainly there's an association with poverty. It's going to occur where you don't have very good sanitation. People are defecating in the open. There's a lack of proper pig slaughtering facilities. The pig and pork inspection and control is poor. And also where the pig husbandry practices are rather not very proper, and pigs are just allowed to roam about to look for their food. However, we do find this spreading in other areas because of immigration. Countries where pork is not really consumed, for example, in the Middle East, they import a lot of workers to come either to work in their homes or to work in construction, and those people bring their tapeworms with them and then are able to infect the local people. Also, a lot of people nowadays, when they go traveling, they like to do ecotourism and go out to rural areas where they may have exposure to this parasite. And then also in Africa, we were seeing a lot of transport, marketing of pigs across borders, and those pigs were taking their parasites with them. And in these countries, we often found that transmission was very focal. There are areas where pigs were being raised, and that's where we're seeing the highest risk in transmission of this parasite. Other areas, they may not be having transmission at all. So this is the most recent map of endemicity of Taenia solium from 2015 from WHO. And so you can see this is very prevalent throughout the tropics, sub-Saharan Africa, South and Southeast Asia, and then most of Latin America. And you can barely see that the island of Hispaniola is also colored here. And a lot of that information from Africa, especially the Eastern and Southern Africa, came from these studies that I was just speaking about. So a bit more about this parasite. It's caused by what we call the pork tapeworm. The adult worm is in the small intestine of humans, and it can grow to be about 5 meters long. Usually it's about 3 meters long. This is Dr. Ana Flisser in Mexico. She's been conducting research on this parasite for decades, and she does experimental studies with chinchillas. And so she's holding up an adult Taenia solium tapeworm. Usually people only have one tapeworm at a time. That's why it's called solium. So these tapeworms, they grow out in segments, and each one of those segments, and the worm is hermaphroditic. There are both male and female organs in each segment, and then they produce eggs in the segment, and there are about 50 to 60,000 eggs in each segment. So they release one or more segments at a time, and they pass out with human waste. So then the eggs are in the environment. If people are defecating outside where these pigs are roaming about, the pigs love to eat human waste. They're coprophagic. So they'll actually follow people when they're going out in the bushes in these areas for a treat. And so they eat the waste, and then they consume the eggs of the tapeworm. And then they develop the larval stage of the parasite. The egg will hatch in their intestine. The embryo will come out, penetrate the intestinal wall into the body, and then encyst mostly in the muscles, the skeletal muscles, cardiac muscle in the heart, but it also has predilection for the central nervous system and can go to the brain as well. So those are the larval stages of cysticercus or cysticerci. And this is how they look. Normally, these pigs don't show any ill effect of infection. They're often not living that long because they're slaughtered for consumption. and they may look like the healthiest pigs in the community. So when they're slaughtered and they're found to have these cysticerci in their muscles, oftentimes they're condemned, and then the farmer may be asked to reimburse the pig trader who's bought the pig the money that was paid. Here you can see this is a masseter muscle of a pig in Tanzania that I was there for necropsy, and it had thousands of cysticerci tenosolium in its muscles. Before it was killed, it looked very normal. So you can also look. So each one of those is a cysticercus, and if you ingest that, then you can develop the adult tapeworm. And so you can actually look at the ventral side of the tongue, and with high intensities of infection especially, you can see the cysticerci there on the tongue. And so the pig traders found out that when they came out to these rural areas and wanted to buy the pigs, they could actually do an antemortem exam of the tongue, look for these cysticerci, and if they were present, they would refuse to buy the pig, which is devastating for the farmer. As I said, these pigs look very normal, healthy, and so the farmers were selling these pigs when it was time to have some money to cover some major household expenses like sending their kids to school and paying the school fees. So you can imagine this was very devastating for them. So another problem occurs though when humans ingest these eggs. They can also have the larval infection as well. So for example, if someone has a tapeworm, they're not very hygienic, they can have the eggs on their fingernails and infect themselves with these cysticerci as well, develop cysticercosis. Someone may be having the tapeworm and they're preparing food for you. Maybe they're a street vendor or something like that, or even in your home, preparing your food, and they contaminate the food with these eggs. You can become infected that way. There was an interesting story here in the US of an Orthodox Jewish community in New York, where of course they don't eat pork, but several of these families were having several family members coming up with neurocysticercosis. And so there was a baffled as to how this was happening. So the CDC, I think, sent some of their EIS officers there and Dr. Peter Shantz to investigate how this was happening. They all had something in common. They all had cooks from Latin America, from endemic countries, and those people were found to be infected with the tapeworm. You can also, through contaminated food and water, from environmental contamination, maybe sexual practices, other ways that you are at risk of ingesting these eggs. And then you develop the larval stage of the parasite. In Asia, interestingly, we see a lot of this subcutaneous cysticercosis. You can see all these nodules under the skin. So you can easily do a biopsy and determine if they have a cysticercosis. And as I mentioned, the predilection site is the central nervous system, and we're now finding that neurocysticercosis is one of the most common preventable causes of epilepsy. I've seen radiographs of people with tens, even 100 cysts in their brain. They don't know they're infected. It hasn't affected them. These cysts are able to camouflage themselves for months, even years. And then something happens. The person may be treated with a drug, or just with time, these cysts start dying. They lose that camouflage. The host body has an immune response to them, and then you develop various neurological sequelae, epileptic seizures being the major one. Some people call this Swiss cheese brain. So as far as diagnosis, we can do serological testing, PCR in both humans and pigs, Copper PCR for humans to look for the tapeworm infection. As I showed you, you can do that lingual exam or necropsy of the pigs to look for the cyst. In some cases, the pigs may have very low intensities of infection, and you may miss them with a routine processing at the slaughterhouse. Many of these neurocysticercosis cases are picked up through imaging, especially CT, MRI, scanning. People may come into the hospital for a fracture or something, and a radiograph is made, and then they're found to have cysticerci. I know in South Africa, many people were being found infected just incidentally. As I showed you with that Asian strain of the parasite, a lot of people have subcutaneous nodules. You can easily biopsy those. And you can do a fecal examination for the tinea eggs in humans, but as I mentioned, the eggs of tinea solium look like other tinea infections. So you'd have to do other exams to actually determine if it was tinea solium. So in 2010, this is the original list of neglected tropical diseases of WHO, which had been around for several years. And so these diseases were highlighted at the international level, got a lot of attention. And then in 2010, there were 4 other diseases added: echinococosis, foodborne trematodiasis, rabies, and tineiasis cysticercosis. I think a lot of that information that we were able to put together from Africa helped convince that this was truly a global issue. So it was included with these other zoonotic diseases in 2010, and this made a great difference in attracting more attention internationally. And then just 2 years ago, we had these other 3 NTDs added to the list. So measuring the burden of tinea solium tineiasis cysticercosis is so important to provide us that essential evidence base for making the case, securing the political will, and giving this more priority for attention, and also providing the basis for provision of financial and technical support. And also, you really need that information to do cost-benefit analyses. And as I mentioned early in the talk, it's not just looking at the health impacts, but also the agricultural and the other societal impacts that these diseases are having. In the mid-2000s, WHO put together an initiative to estimate the global burden of foodborne diseases. This was an initiative that went on for more than 5 years. I think it was about 7 years. And how this took place was appointment of experts as the Foodborne Disease Burden Epidemiology Reference Group, called the FERG. And so there was a focus on contamination of food with enteric and parasitic pathogens, as well as chemicals and toxins. So there were 3 main working groups put together, one for enteric, one for parasitic, and then one for chemicals and toxins. And I was appointed to the one on parasitic pathogens. And then we secured expert groups to do systematic reviews on the burden of these different foodborne diseases. We actually considered, I think it was about 31 foodborne hazards, and then we commissioned these systematic reviews. And then we would come together periodically and present these findings to the entire group. And so neurocysticercosis, a burden assessment was done on it, a systematic review was done. As I mentioned, these neurological sequelae associated with neurocysticercosis. And here you can see that of those people seeking care with neurocysticercosis, almost 80% were having epileptic seizures, about 38% were having severe headaches, 16% focal deficits, almost 12% with signs of increased cranial pressure. And then there was also a linkage with stroke and dementia that has yet to be explored. They also determined that of the proportion of people having epilepsy, 29% of those in endemic areas, or persons having epilepsy in these endemic areas, 29% of them, it was because of neurocysticercosis. So if you go to an endemic area, you determine your prevalence of epilepsy, then you could determine that about 30% of those people were actually having neurocystosarcosis. And then we were actually able, with that information, to estimate the DALYs related to cystosarcosis, about 2.8 million. And again, that's just the health burden of the disease. So from that initiative of the FERG, we came up with the top 10 foodborne hazards, and Teniosolium was the only helminth infection included in that top 10. We could also look at these estimates at the regional level. This is showing the 6 different regions of the World Health Organization. So the first column is Africa, the second is the Americas, the third is the Eastern Mediterranean, fourth is Europe, then South Asia, and then Western Pacific, Southeast Asia, Western Pacific. So this is just showing you a comparison of these different parasitic diseases that we reviewed the burden, showing you the pink part of these bars was due to cystosarcosis. So you can see that in Africa especially, but also in the Americas, in South Asia and Southeast Asia, Western Pacific, this was quite important compared to most of the other parasitic diseases. Also, at about the same time those results came out, the World Health Organization and the Food and Agriculture Organization of the United Nations had commissioned another group of experts to look at foodborne parasites, specifically parasites, and they looked at it from a different way, the burden in a different way, looking at various criteria, both health and agriculture and trade and many other issues. And so they had this multi-criteria based ranking, and again, Teniosolium came out top, Echinococcus granulosus second. Of all of these foodborne parasites, just to emphasize the importance. So as you remember on the map of endemicity, the US was blank, but we're seeing more and more cases of neurocystosarcosis here in the US. It's almost entirely in immigrants coming into the country. So I know that more than 1,000 people are being diagnosed in this country now with neurocystosarcosis. And interestingly, Seth O'Neill from Oregon, he's a medical doctor, did a review looking at hospitalizations as a result of neglected tropical diseases as well as malaria. And he looked at the specific neglected tropical diseases, and he was able to come up with figures for the period 2003 to 2012, showing that hospitalizations and cost for those hospitalizations for cystosarcosis was much greater than malaria and much greater than the total of all of the other neglected tropical diseases here in the US. And again, most of these hospitalizations were of people not originally from the US, most of them were immigrants who had come here with their parasite. Has not been able to find out from which country these people came, so we don't know, but there's speculation that many of them were coming from Central America and Asia. In any case, this has led CDC to include cystosarcosis on this list of 5 parasitic diseases, neglected parasitic infections initiatives that they have ongoing right now, which is targeting for public health action, looking at the number of people infected, severity of their illnesses, and the ability to prevent and treat them. So because of these increase in cases, they've added cystosarcosis to this list, or included it in this list. And going back to 1993, the International Task Force for Disease Eradication, in their initial list of potentially eradicable diseases, they targeted 6 as being potentially eradicable. as you can see here, these are the 6: polio, mumps, rubella, dracunculiasis, guinea worm disease, and lymphatic filariasis, as well as cysticercosis. And I would argue that cysticercosis, certainly of that 6, has received much, much less attention. And again, we go back to this issue of it being zoonotic, and perhaps that's part of the problem that has resulted in some confusion as to who actually should be looking at this particular disease of those 6. I know that the ITFDE has considered cysticercosis on 3 more occasions since 2000, and I think they still include it on the potentially eradicable diseases list. So there's actually been a proof of principle project now has been undertaken in Peru with about $20 million from the Bill and Melinda Gates Foundation, where they showed the proof of principle of elimination from a specific area in northern Peru and near in the area of Tumbes on the north coast of Peru. And for this elimination program, they used niclosamide as an antiparasiticide for teniosolium for treating humans. They use oxfendazole, which is very effective for treating porcine cysticercosis. 1 dose at about 30 milligrams per kilogram will kill all of the cysts in the muscles. Won't kill them in the brain because it doesn't really cross the blood-brain barrier very well. But 1 dose, usually at 30 milligrams per kilogram, will kill those cysts in the muscles, but it takes about 3 to 4 months for those cysticerci to actually die and disappear from the muscles for the host body to take care of them. So if you're going to treat, the farmer wants to sell their pigs, they should treat them, 4 months before they plan to actually sell them. They also included a vaccine that's been developed by the University of Melbourne in Australia. Marshall Lidowlers produced this vaccine. And so that was also included in the program. And it's now available, it's being commercially upscaled by a company in India for use globally. Also in this program, they used coperantigen testing to identify persons with the tapeworm and then monitor over time whether they actually were cured of those infections. And then to monitor in the pigs, they actually did necropsy and slicing and dicing of the pig carcasses. I was there at one point, and just a huge room of people sitting with these pig carcasses, slicing and dicing. I mean, that room must have been 4 times as big as this one. So you'll notice that there's something missing, something important missing. A lot of concern has been raised about sanitation. There was no sanitation improvements included in this program. So now the thought is whether we can actually transfer this information to other areas. I mean, other areas don't have $20 million to do such an intensive program. So there are now studies ongoing in Zambia and in Tanzania looking at a less intensive way of trying to eliminate this disease. And the papers from those studies should be coming out in time now. So we face challenges with regard to elimination of Teniosolium. You only need a few tapeworms in these communities that can continue contaminating in the environment. You can have low intensities of infection in pigs, and so they can be missed when they're slaughtered. Also, people and pigs can move from community to community and take their parasites with them. We're still having some issues with diagnostic tests for detection and monitoring, especially on the pig side, because the diagnostics we've had are not specific enough to actually play this role. So we're still working on that particular diagnostic capacity. Then also we have Teniosolium occurring in areas with other parasitic diseases and other tropical diseases. For example, schistosomiasis, where there are mass campaigns to treat for schistosomiasis, not realizing that that drug at the level, at the dose that's being given, may actually cause problems in people who may have cysticercosis infection. And then also because these neurocysticercosis cases may remain non-symptomatic for months or even years. And so you may not know that you have transmission for a long period of time before people start having seizures and they're determined to have a neurocysticercosis. And so we're using the pigs more as a sentinel for transmission because we can detect it much more rapidly. So I just wanted to put together that information to indicate how important this disease is at the global level. And certainly these major consequences related to infection merit much more attention to this disease. As a cause of epilepsy and even death, we have records in the US and Brazil and other places showing this is a cause of death of people. It makes the pork unsafe to eat and also reduces the value of the pigs and pork from them. It poses a major constraint for the smallholder pig production and marketing. And then there's a lot of stigma attached to communities and farmers that are producing pigs that are found to be infected. The pig traders may avoid them. And then also people with epileptic seizures, you know, they have serious stigma attached to them. They may not be able to get a job. They may not be able to get married. Women with epilepsy are at greater risk of rape and many other serious impacts from that stigma. And so from the Africa studies, we saw that over time we had teams of veterinarians, of medical doctors, of social scientists, and all addressing this as a way of getting into the community and having this One Health kind of systems approach, addressing many other factors in the community. So lastly, I just want to tell you quickly about an initiative we have in the Caribbean now, trying to assess the burden in the Caribbean basin. And so with regard to elimination, many of the countries in the region, we don't have much information about the situation of cysticercosis. We do know that old studies have shown it to be very prevalent throughout the region. So we have reports from several of the countries, but in others such as Dominican Republic, Guyana, Paraguay and such, we don't have any information. And there have been some recent cases in Chile and Argentina, but mostly in immigrants. Just to show you some of the previous studies showing that this has been present. And in Haiti, for example, that study there, I think it was a survey of only 9 people, and we've not seen anything more coming from Haiti. So we wanted to map the occurrence of Teniasolium at the national level in the region, and starting with porcine cysticercosis, because that's a much easier way to look at transmission. We looked at published papers, reports from the government, reports from the World Organization for Animal Health, OIE, because the countries report to OIE about these cases. And so we were able to identify areas where we had reports of porcine cysticercosis as well as human cysticercosis. So this was the initial map we worked with. As you can see, Guadeloupe and St. Lucia reported cases, but as it turned out, these were imported cases coming from Haiti and Dominican Republic of people with neurocysticercosis. So now we've gone further and have actually identified areas where there's a lot of extensive pig keeping, and we've come up with this risk map for Teniasolium based on porcine cysticercosis reports. And so we're starting to address these different areas or different countries and territories. We've also gone further with modeling the distribution of pigs kept under extensive circumstances to help us solidify that risk map. And so this is what we've come up with in relation to where porcine cysticercosis has been reported in those areas with high densities of pig production under extensive circumstances, where pigs are allowed to roam about. And you can see here Haiti, parts of Guatemala, El Salvador, Honduras, Nicaragua, are certainly areas that we want to investigate. So we had reports from 16 out of the 41 countries and territories in the region. And so now we're going further and starting to go into some of these countries and working with the local scientists to conduct surveys at the community level to look for cysticercosis in the pig populations. And so we've initiated studies in Dominican Republic, Guatemala, and we've applied for projects in Honduras and Haiti. And so I have a postdoctoral scientist, the lady you can see in the photo here. She's from Dominican Republic. She's a veterinarian, did her PhD in Japan. She's fluent in Spanish, English, and Japanese, and she loves to work with pigs. So we're very happy to have her on board. So lastly, I just mentioned that in July, we're hosting the 14th Congress of the Central American and Caribbean Association for Parasitology and Tropical Medicine on St. Kitts, and you're all very welcome. The registration is open. You can submit abstracts, hopefully before the 15th of April. We may extend that by a couple of weeks. But anyway, you're very welcome to come and join us on St. Kitts for this meeting. And thanks again for having me here, and if you have any questions, I'll be happy to answer. And this is kind of the view from my bedroom, but in any case, you're all very welcome to come and visit us on St. Kitts anytime.
Thank you, Dr. Willingham, for an awesome presentation. As we traditionally do here at the One Health Academy, I'd like to present to you a flag that was flown up over the Capitol.
Oh, wow.
So thank you so much for
Terrific.
sharing your time and information with us tonight,
Oh,
with everyone
appreciate it.
online. Really, really appreciate it. And we are short on time, everyone. So I will take one or two questions, but just want to let you know that we are starting a new networking activity after, since ASM does need us to be out of here. Tonight we'll be meeting at the Tabard Inn, which is right across the street, a little bit diagonally up on N, and we can continue networking there. So one or two questions, and then we'll wrap up and head out. And those of you that want to join us and continue chatting with Dr. Willingham, we'll be at the Tabard Inn. Questions with the mic? Anyone burning questions or thoughts? Yeah.
Kathleen Genshammer again. I think that, the question about how to get the farming veterinary community to pay for vaccines that really ultimately can affect human health is really such a incredible question. And of course it extends beyond parasitic diseases, but we see that question over and over again, and I don't know what the answer is, but
yes, I mentioned that there are these elimination studies in Tanzania and Zambia that have been ongoing, and so they actually will have more information about the farmers' acceptance of these vaccines and what they're willing to pay for them, and actually their compliance, because it's not just one vaccination. You have to have a booster and then an annual booster after that. So that will be coming out in these publications that should appear soon.
Really great talk. I have a quick question. A lot of this is focused on kind of lower middle income countries and that kind of setting, but in the US and other higher income countries, we're seeing an increase in the pasture pig production sector, a lot of diversified agriculture, and some of these communities are nonetheless dependent upon immigrant farmer populations. So are we at all worried or doing any surveillance within some of the populations where it could reemerge?
Very good question, and I certainly think that should be considered. Because having lived in Europe and seeing this movement to put pigs back outside, certainly knowing the situation with Taenia saginata, the beef tapeworm, and how farm workers defecate in the pens, and lots of cattle in Western Europe being infected with Taenia saginata, the same could happen here. Oh.
Okay. I'm sorry, you guys, we're already over at 8, so I'm gonna have to ask you to ask afterwards. But thank you so much for coming. Really great to see you in person. Thanks for those online that have tuned in. And please make sure to sign in the back if you're able. Come into the back to take any money. And yeah, thank you. Please join me in thanking Dr. William again for all.
Thank you.